Be heard. Can you hear me? Can you please wave your hand if you can hear me? All right, thank you very much and welcome to today's ECHO session. We'll be looking at yet another interesting one on PIMS series. And today we are looking directly patient identity management system. And just like we had last week, we will be asking questions to some facility members on PIMS, and we hope you provide good response to that. And today we have one of our experts on PIMS in the person of Johnson Alonge, who will be making presentation today. But before I call up on Johnson, we want to call on the Federal Ministry of Health to quickly give us an opening remark. And standing by to do that, we'll have Labake Ikundayo. Labake, please, you may want to unmute yourself and go on with an opening remark from the ministry. Labake, over to you.
Yeah, thank you, Prosper. Good morning, everyone. You are welcome to another exciting and impactful session on ECHO this morning. Today's topic is a very important one, and it's a continuation from the last time on PIMS. Would like to implore all to try to listen attentively as usual and be able to learn so many lessons. And if there are clarifications that are needed from you, facilities, you can quickly ask your questions, and then more light to be thrown on it by our facilitator for today. So on behalf of the Federal Ministry of Health, the leadership of NASCA, Dr. Akudo Ikazu, and then side, Dr. Adibobola Basharu, I welcome you all once again. SMEs, facilitator for today, CDC representative, healthcare workers, NASCA colleagues, and the 5 Street team. You are all welcome, and wishing you all a successful from this morning. Thank you. Over to you, Prosper.
Thank you very much, Labake, and thanks to the Federal Ministry of Health for all your support, NASCA division in particular. Thank you very much. Again, I want to call on the CDC representative, Isa Abbas, to give us a goodwill message and also a brief insight on what we are talking about today. Mr. Isa, please, you may want to unmute yourself and go on.
All right, thank you, Prosper. Good morning, everyone, and thank you, Labake, for the wonderful opening remark. I think I'm not gonna, take much of our time. But like you said, let me first of all begin by welcoming everyone that made it to this today's session. Like Labake mentioned, it's a continuation of the 2 previous sessions, and it's aimed at bringing everybody on the same page around patient identity management system development, implementation, and maintenance. I always mention, the main or primary objective of patient identity management system is to have an opportunity of creating an enabling environment for patients to access care universally, access care irrespective of location of registration. This will help in reducing a lot of IIT and self-transfers that are undocumented, which result to us having multiple counts of individuals as patients who currently receive ARVs. Alongside this primary objective, it will also help us prevent multiple registration of individuals across locations, being it within partner or within a state or states that are managed by the same partner, or within states that are managed by different partners, different agencies. So you can see that this is very important aspect of this year and next year in particular, as far as this project is concerned. Lastly, I would like to draw our attentions that PIMS can only be successful if we have quality fingerprints data. Quality fingerprints data means you have complete, capture of all the patients that are currently on ARV, and as well as have fingerprints not just captured, but that are valid and are usable for deduplication and also PIMS implementation. So thank you very much, everyone. I'll pause here and do enjoy the rest of the sessions. Thanks.
Thank you very much, Issa, and we do hope to have you again respond to some questions at the end during the Q&A. Mr. Johnson, can you kindly unmute yourself and share your screen, and let's have your presentation.
All right, thank you, Prosper, and good morning, everyone.
Good morning. Can you share your screen?
Just doing that. Please confirm you can see my screen now.
Yeah, I can see it.
All right, thank you very much. All right, good morning, everyone, and welcome to this echo series on PIMS Identity Management System. So what will be our learning objectives today? Today, the whole objective is to sensitize participants on the call on PIMS. I know we've been doing a series build up to PIMS. We've spoken to the PB itself, how fingerprints are being captured at each of the facilities. So this will be giving us the learning curve on how PIMS was implemented and the achievements that we have made so far. So again, we always try to bring these slides for us to understand that PIMS is a collaborative effort. Let's not look at it as probably one IP or one organization working on PIMS itself. I think it takes a whole community to get this out there. And we always want to say, as one of my colleagues, Kenneth, is always saying that the facility staff, the healthcare workers are the real MVPs at the end of the day. So we want to always put this narrative out here that this is a community effort. It's all the organizations put together that has this project. So we should see it as our project and not Ministry of Health or Vice-3 project, but it should be seen as our project and we should take it as our baby. So the background for PIMS. PIMS came about as it's been difficult to uniquely identify a patient in the facility itself, meaning that patients move across different facilities, and most of the times, those patients, when they move across facilities, they get to be registered all over again, get to go over the same cycle. So that's better the need for PIMS, which PIMS, one of the objectives is to maintain a central registry for all clients, meaning that you have at least the minimum data set for that client when they move from facility to facility, and within the facility itself, saying that the new, to know if it's a new patient or a patient that is currently on, that is currently using the facility at the time, and also linking clients' results across, linking clients' data across each facilities that the client has been to. And most importantly, as Malam Issa has said, the roaming allows clients to roam from one facility to another and still have some of their records that the healthcare workers can use to make informed decisions at the end of the day. So again, the objectives, not to repeat again, maintain its central system where all clients are uniquely identified at the national level. So we have a system where you can always view which clients, which facilities have they been to. Minimum data sets enables the clients to access care in different facilities. So one other thing that we're trying to do here is to build system-centric data, right? Imagine a client moves from one facility to the other facility and is new within that state. Who can the client reach out to? There have been talks from PIMS, there have been talks of we having mobile apps that will have locations. Like you come to a new place, you have what they call it, you have like a mobile app that gives you location of facilities that are being supported for you to go pick up to go have a drop pickup at those facilities. So give or take, we're trying to build client-centric applications, ways to authenticate these clients and link this client's record in a longitudinal pattern so that you can see the history of these clients over time. So those are one of the objectives that we have for PIMS. So components of PIMS. So PIMS, as we will say, we've been saying PIMS, Patient Identity Management System, but PIMS, you would see it's systems that you've been familiar with. It's not a new system. People at the facilities are not interacting with give or take new systems. It's still the EMR that you know, the NDR that you can still speak to at the end of the day. So you have components of the NDR being used in such a way that, okay, these patient records are on the NDR. These are records that were uploaded from the facilities from time to time. They are not new records. Now, currently, within the country, we do have about 3 nationally used EMRs, which is the electronic medical records, the Nigerian electronic medical record. We have the LAMIS Plus, and we have the MODIP. The only things with this component is, on this component, you will have some new models that PIMS can speak to, or more or less the EMR can speak to PIMS. So you just have new models with flows, but these are elements that are plain on the UI. So give or take, they are just fields to be entered at the end of the day. So it's still the EMR you're used to that PIMS is riding on. So we try to do a user story here. So case one is this: outside of his facility, ABC, Mr. John Doe travels to facility XYZ to pick up drugs. When Mr. John Doe is verified at facility ABC, PIMS is employed, and the minimum data set, which we speak to, the minimum data set is returned to that facility such that Mr. John Doe age and last medical regimen is returned to that facility for the health worker to make decisions on that. Yes, we get that the health worker gets to ask the patient some questions, but you already have informed questions from PIMS that gives you an idea of, okay, what drug regimen has this client been on? When was the last drug pickup? How was the duration of the last drug pickup? So those are one of the things that PIMS can help out with. Also, case two, we have the State Specialist Hospital Gombe provides care for Mr. John Musa, a long-distance truck driver who is PL/HIV and lives in Gombe. He presented himself to ZH Sapele and received a refill after running out of ARVs due to his travels. In order to prevent reporting Mr. John as having an interruption in treatment, State Specialist Hospital is updated via PIMS. So what this is speaking to is Omalami first spoke to the fact that we have patients moving from one facility to another facility, probably due to work, due to transfers, or as the case may be. For those patients, when they get to those facilities, they can present themselves, go through PIMS, get verified, get their minimum data set, pick up drugs, and their parent facility or facility where they initially used to take drugs will get updated via PIMS, letting them know that, oh, a patient of theirs has moved to a certain state and has picking up drugs, so that you don't mark that patient as IIT, right? And also for that new facility that where the patient has gone to, don't more or less mark them as a new patient. So he allows free roaming. Also speaking to this case is client-centric system that we're trying to build. So if we look at it, say Mr. John Musa now, for example, gets to the new state where he is and he's not used to that state, he just finds himself in that state. How does he know the supported sites in the state? Where does he go to? Where does he walk into? So that's where thoughts are in process for probably a locator app in which he can just go on it, look for a locator. Say, for example, he went from Gombe to Delta State. So in Delta State, he gets a locator app, he can log in, or probably open the app and sees location of facilities that are supported and go to those facilities. Either ways, he could even see his clinic dates. Clinic dates of the facility there, so that he can walk in and do a drop pickup or what he or she needs to do at the facility, whatever the case may be. The building blocks. So building blocks of PIMS, as we earlier stated, we have the EMRs, we have the PIMS engine itself, we have the NDR itself, and we do have our deduplication engine within the NDR block. So this is the building block of PIMS. So PIMS workflow. So the workflow for PIMS, this is the workflow for PIMS. So speaking, we have a patient, Jane Doe. At this point in time, Jane Doe visits a health record facility. First point of contact, and the fingerprint of that patient is scanned to be verified by the EMR and the PIMS module on the EMR itself. When a scan is done, if the patient exists, right, what happens is that the PIMS system itself returns a minimum data set, which we'll see something that looks like in some other slides. It returns the data set, which from that, it goes into whatever activity the client is further pushed down to acquire the facility. So depending on the flow that happens in the facility. So from there, it's the normal flow that you get in any other facility. So from there, the record or whatever is done is also uploaded onto the NDR. After that is done, you get a feedback from PIMS. Looking at the arrow here, you get a feedback from PIMS, sorry, my bad. So you get a feedback from PIMS that goes back to the facility, the health record facility, to give an update. As the case may be, if it's another facility, that other facility also gets an update based on records that changes that have happened to that patient from another facility. So you get that from PIMS. However, when building the systems, we understood that, okay, we will have cases where the patient is new. So if the patient is new, what happens? The PIMS, when you don't get feedback from PIMS, what do you do? The next, the client is, you do what you always do in your facility. You capture the client, register the client, take the fingerprints, 10 fingerprints, minimum of 6, but 10 is always good. Making sure that the finger qualities for this are give or take above 80. If we can get 80, the better the quality, the better for the system. So you take the fingerprint, this fingerprints are scanned. This is sent to the NDR. We do the deep duplication, and the flow continues. So that's basically the flow for PIMS itself as it stands. So the biometric verification, this is what it looks like. So it's still, as I said, PIMS is riding on what we currently have on the various EMR, right? So I think people at the facility are used to this UI. So that's why we brought this UI to show you that, oh, still the same UI that you have, but with PIMS, it's just a bit of a slight modification, but you still have this UI. What you have the different fingers that you get to scan. So the PIMS model, because we have the different EMRs that are speaking to PIMS, and on any end, we're not the one building the different EMRs for the different facilities. We have like a login model. So the thought process here is that not everyone that can access the EMR should be able to access PIMS. I think you should have some other privileges to access PIMS itself. So when the model pops up, there's the need for a login and username and password, so that we know that, okay, because everything on PIMS is being logged. We want to know people that are trying to access, people that are trying to verify fingerprints. So that way we have the username and password so that we can say, oh, Mr. A tried to access PIMS to verify someone's fingerprint so that we do not abuse these services. So for that, we have a UI for login, which is still within the model for login. So when the user logs in, you get to see the next screen, right? So on the screen here, it's the same, looking at how we capture for biometrics, right? But the only difference with PIMS now is that you do not capture all 10 fingers because you're not trying to verify all 10 fingers at any point in time. You're trying to verify one fingerprint. One fingerprint is enough to verify a patient, to tell you who is this that is trying to access the facility. So for PIMS, we have the 10. So if we look at this now, it means from the picture that we can see, it's the left thumb that was used to do this verification at the point in time when this screen capture was done. So the left finger, and we can see the quality, it's a 95%. So we have different gradients of color. So for captures that are less than 60%, we between 60 and 70, I think we have a yellow gradient for that. You have yellow, so you see the 95%. If it's around 65, you see it's in yellow, saying that this quality, it's not that great, but it's still usable. However, from 60 and below, we have that in red, and if it's in red, you wouldn't be able to scan. The scan button in itself will be deactivated for you to please, the verify button, pardon me, the verify button itself will be deactivated for you to please rescan that client or patient. So on the search bar, we can see what we call PIMS only and facility at PIMS. So by default, the radio button is going to be on PIMS only. When it's on PIMS only, meaning that this search will only happen via PIMS. No search will be done at the point of the facility. So it's a direct search on PIMS. Search will be done on PIMS and you get a response. However, if you want to search both facility and PIMS, you click on the facility and PIMS. At this point, search will be done at the point of the facility itself. So the fingerprint scanned will be verified across the facility system first to get a feedback. If there's no feedback on that, then it proceeds to PIMS to do a search. Most times we get to see that the facility search could be quite, it's usually when you do the facility and the PIMS, it's slower than doing PIMS alone at the end of the day. So for the result that is gotten back, so if you do a search and it goes to PIMS and there's no feedback, what you get, you don't get any, you see no result found, meaning that this patient has no fingerprint that matches any other fingerprints within the system, meaning that more or less this is a new patient in the system, and the registration flow can go forth for the facility staff to capture and upload to the NDR. However, this that was done here, return the search for a patient, and this is some of the minimum data sets we were speaking to. So what we have here is DOB, date of birth, sex, the patient identifier, the facility in which the person is originally taking drugs from, or his base facility where he's accustomed to going to, the local government itself, the state, supposed to get the ART start date, the ART start date, the last drug pickup, the last regiment, and the last viral load, and the date for the last viral load itself. So this is returned at the end of the day. Yeah, okay.
Hello, Johnson.
Yes, I'm with you, sorry. So this is returned at the end of the day. So we have, I'm looking at the global ID. So we have the global ID. The system was built in such a way that we could do a search with a global ID, but for now that has been deactivated. We're not doing search by global IDs. The modalities for that are still in talks. We're still building the algorithm for that. So basically for now, search are being done by fingerprints itself. So the patient comes to the facility, append their fingerprints on the scanner, it's scanned, sent to PIMS. If PIMS only is chosen, sent to PIMS. PIMS does a search within the system, and the search is really fast. It's by our projection that we've done and our test that we've done, that was done under 4 seconds. The highest we got was 4 seconds, give or take. So within 4 seconds, you get a feedback. Once you get this feedback, you proceed to the next phase of what we want the clients to do at the facility itself. So that's that on patient identity management system. Thank you.
Wow.
And over to you, Prosper.
Wow, thank you very much, Johnson, for this wonderful presentation. You may want to stop sharing your screen at the moment. So okay. Apparently it appears somehow technical, but this is what happens in our facility. And then for me, my understanding of PIMS is just a unique way of identifying a patient who is on treatment throughout the continuum of care, whereby the patient can move from Abuja and probably get to Enugu, and then maybe in one local government and Soka local government and need to access care. They just go there, and with the PIMS system, the patient can be able to be identified as a patient who is already in care in Abuja, and then without much stress, and the person can access care if it is to pick up drugs or something. Every history of such patients will be known, and then the patient will be able to identify care. So Johnson, one of the questions I wanted to ask you is that, are there any means of identity in case of system failure? Maybe a patient moved from Abuja to Nsukka and then get to a hospital that has PIMS being implemented in a facility, and then the system is down, system breakdown at that particular facility in such a way that the person cannot be able to, the person's fingerprints cannot be used to identify. Is there any other means that can be used to identify such a patient for the patient to be given attended to? I don't know if my question makes sense to you.
Yes,
Hello,
Prosper. Yes,
yeah.
yes. Can you hear me?
Yeah, I can hear you. So,
okay, thank you.
Yeah.
Okay, yeah. So, while building the system, while this came up, so even better put it, what came up was, if we are at a remote facility where we do not have internet, because PIMS, as we all know it, uses internet to do this verification. You have to have internet to go over that. So there was questions around, if we do not have internet at the point of the facility, how do we go about this? Does that mean we will not use PIMS? So also PIMS, the system in itself, if there's a breakdown of system or there's no internet at the point of the client being in front of the health workers, or the system will be to treat the client as a new patient, right? Capture the fingerprints, do your normal registration, provide service to that patient. When you do your upload, you extract and do your upload the normal way most of the facility people do it. When you upload, this PIM system should be smart enough to do the checks and balance and see that, oh, okay, this fingerprint that you just captured from facility A that was uploaded, that fingerprint match a certain patient in facility B that exists on treatment. So at that point, when that is seen, the facility in question, that's facility A now that has done that capture and uploaded to the platform, gets a feedback also and says, this patient that you initially captured was a patient that belongs to a certain facility, and that is still, the facility A gets that feedback, and from there they can treat it accordingly. Yes, the SOP standards will be given to each facility on how to treat this situation during reporting and so on and so forth.
All right, thank you very much, Johnson. So I will open up the floor for questions, but I'd like to ask specific questions to those on the call, the facilities on the call. Maybe we have some of the IP. So we did send a mail and ask that you be informed of these questions. So please, I want to ask that all the facility representatives that's supposed to respond to the question, probably you can just need to raise your hands and then I will call you. I have a few questions to ask. So can I have those facility representatives that's supposed to respond to questions? Can you please raise your hands and I will call on you? Maybe from CFN, from HPN, AP, CIHP, AQs. Can I have your hands up? There are questions for you. Okay, so we'll have Obiakpo, KPIF Obiakpo. So this is IHPN, so I believe you are representing IHPN in this. So the question is, can you unmute yourself, KPIF Obiakpo? Okay, good. So the question is, what do you understand about patient identity management system? What do you understand about it?
Good morning, everybody.
Good morning.
Yeah, so my name is Israel, and I'll be speaking on behalf of IHGN from KPS SOBIAPO. So patient identity management system is just, to the best of understanding, is just an act to ascertain the unique identity of a particular patient. So from what we have now, though we have different unique identity on how to get a patient a unique identity, from our own angle, we're actually using the patient biometric and the fingerprints. In as much as we all understand that no two individuals share the same print. So the PIMS, that is the patient identity management system, is just an act to ascertain a unique identity, to ascertain a unique identity for individual.
All right, thank you. So, see, hold on, that's a wonderful one. So, well, what's your personal experience about this? Have you experienced using it?
Have I?
So, what's your experience about PIMS? Have you, in any way, experienced maybe from the PBS aspect of it?
Maybe have I experienced what?
I said, what's your experience about PIMS?
My experience about PIMS. So I will relate it with the PBS drive that we've had
exactly
in our facility so far. So my experience so far, though, let me just speak from KP point of view, because to be honest, the drive wasn't an easy task, because we're trying to tell the KPs, and you know how actually KPs behave and the way they reason. They actually don't reason from normal perspective of normal way people, because if you are reasoning towards a reasonable level.
I hope you are not. Well, we don't need to. You don't need to tell us how they reason, because that may be, they may feel offended with that. You don't know how many.
Sorry. All right.
You also have KP folks on the call.
All right. Sorry. So I just need to the challenging and what I've actually expressed over time is try to see how we can convince them and to let them know that, okay, this is the importance of this biometric, so that you can actually assess from what the person on call said, so you can able to actually assess your care wherever you find yourself. So I try as much as possible to see how we can educate them and let them know about the importance of capturing your fingerprints. Though sometimes they prove very, very unavailable. So we now need to just move from our facility to meet them at their various communities from various destinations to see how we can capture them. So my experience on these things regarding this PBS so far, fine, it was fun, but it was actually not an easy task at all.
Thank you very much, Obiakpo, KPIF Obiakpo, for that wonderful perspective. And I believe he represented IHPM. So can we have other individuals, representative, raise your hands? We are waiting for CCFN, for CIHP, we also APIN, AQs, and all other, including some USAID partners that are on the call, because PIMS cut across. So please, I don't want to ask general, maybe there's still time for general question, but please, can I have IP representative, please raise your hand so that, okay. This is still Obiakpo. You have responded. So can I have other IP, please? Can I have your representative raise your hands, please? Where is AQs, CCFN, APIN, CIHP? Okay, why? All right, so we'll have IHP and FCT, Maitama District Hospital. So can you unmute yourself so that I can ask you? Maitama, okay, good. So, so to IHBN, I want to ask this, just a build up to the previous question. What do you think needs to be done to better things around patient identity management? Can you hear me? Maitama District Hospital, what do you think needs to be done to better things around patient identity management?
I think more education need to educate them more. That's the patient awareness, create more awareness.
Okay, that is on the side of the patient. What of on the side of the health workers themselves who are making these services available?
I think training and retraining of the health workers will go a long way in helping improve the quality of service.
Okay, how effective is PBS services in Maitama District Hospital?
It's very, very effective. In fact, it has really solved a lot of problems for us, like duplicates. Then it has improved the quality of data for us, seriously.
Okay, so in essence, it is very effective for you at Maitama.
Yes, yes, very well.
Okay. So can I ask you one more question? Okay, go on, please.
Go ahead.
Go on.
Yeah,
I
have something, I need clarification on two things.
Please go on.
One is the apps for patient. Is it that they will download it and just use it straight, or they need access for them to download or to access the information?
Okay.
One. Then the issue there, well, there was a question asked on if there is no network, no NEPA, how do we attend to a patient who goes to get drug from another facility? Maybe he's on travel, like these truck drivers. The question wasn't well answered for us.
Okay. Okay, Johnson, are you there? Please, can you quickly respond to this so that we'll move on?
Okay, so PIMS is an app. They're not downloading it. As I said, it's still the EMR that is being used. The EMR will be updated with the different modules that consist of the PIMS module itself, right? I think that's the question one. Question two, he spoke to being offline. It's this. If PIMS system cannot be accessed at the point of the patient being at the facility itself, then what happens is that patient is registered, takes the normal flow, the flow you have at your facility. So what you do is you register that patient, take the entire 10 fingerprints, and you upload, because at that point in time, the patient is treated as a new patient, since we cannot verify if the patient exists on our database or not. So the patient is seen as a new patient, you register and you do what you normally would do for that patient, do the upload. At the point of the upload, the platform itself will be smart enough to do this check and verify that, oh, we have this print on this system. We have this print as John Doe on the system, which your EMR at your facility will get a feedback telling you that Mr. John Doe, I'm sorry, maybe any name, Mr. John Musa, that you captured this is not his first time we're seeing him in our system. He has been to another facility. So by that time, I guess you would have been back online. So you get that feedback to your facility.
Thank you.
Welcome.
Okay, so Maitama, does his response to your first question, is it very clear? Because I don't know. The first question you asked, is it very clear now?
The apps for the patient to use and identify a facility when they are away from their own original facility. That apps, is it that there will be the access for them to access the app? Otherwise, any other person can download it and access information that are private. So I feel
Hello, it seems to have lost him. Johnson, can you see?
Yeah, I can still hear you. So for that, what we said here is that we're trying to build client-centric app. We're trying to bring our patients closer to us, right? So we're thinking of innovations to help these patients, so that on their own, they are willing at any point in time to go to this facility and not probably have to call one or two people. That is still in the works, right? There's still
no. Johnson, Just 1 minute. What I think he is asking is the app. Maybe he's thinking that there's a special app that does this work other than what is already deployed at the facility. Does the patient have access to this app, or is until when they get to the facility that the facility will now check from the app to know the patient history? I don't know if you get what I mean.
If it's that he's asking or that he's speaking to, the patient will have to get to the facility, right? There's no app for the patient to check his history. The patient will have to go to the facility himself.
Okay. So I think my time, I know your network is like network has yanked you out, but what's your first question? The patient does not need to have access to the app. It is at the point of contact with the facility that the facility will now check for the patient to know the patient medical history, care history and the rest. So it is at the facility. The patient doesn't have that app. Thank you very much. We'll move on. So we have APIN Benue State. I have enabled you. Can you unmute yourself now before I can ask you? APIN Benue MIMID. Can you unmute yourself?
Hello.
Good. So the question to you is, can you hear me, APIN Benue State?
Yes, I'm hearing you.
Okay, so how does PIMS ensure the accuracy and integrity of patient records? In this case, we are looking at PBS, which you already used to at the facility. How does it ensure the accuracy and integrity of patient records?
It ensures the accuracy and integrity of patient record because it's a confidential something. The PBS is not carried out with another person being involved. It's only the person that is doing it with the patient. Then only two of them. So it's very confidential.
So meaning that at the point of care that another patient cannot have access to the data of if, for instance, two people came to the hospital and then you are attending to the first person. After you are done with the first person, when you are attending to the second person, does it mean that the second person cannot, somehow see what was captured in the first patient? Do you understand?
No, they can't see because it's
all right.
one person at a time.
Okay, so but what do you really understand by this PIMS we are talking about, patient identity management system? What do you personally understand about it?
What I understand about it is that it's a platform that ensures the safety and accuracy of patient biometrics. As in, it's a platform that ensures that no patient is captured, is duplicated anywhere. Once you are accessing the drugs in a particular facility, you cannot be accessing drugs in another facility. So it helps to know the actual client that are accessing drugs. That's what I understand about it.
All right, thank you very much. So CCFN Abia, I have just enabled you. Can you unmute yourself? Let me. Okay, good. So for CCFN Abia, I want you to tell me what's the benefit of implementing PIMS in your facility? Can you hear me?
Good morning, sir.
Yeah,
the benefit from my clearly. Okay, the benefits, there are many of them, but the most important one is to make sure that a patient can easily be identified irrespective of the IP or irrespective of the location where the person was actually enrolled earlier. Whenever the person goes to visit, they can access care. Another one is to make the person actually captured and enrolled instead of the actual person.
Okay, so so far, looking at the one that is you're directly having access to, PIMS, for instance, is in the future, or we are
Okay.
planning towards that, but PBS is already working. So, I mean, what's your experience about PBS? Have you had any challenge with it?
Okay. Yeah, basically the challenge I used to have there is people with fingerprints that are not that legible. Most of them are farmers, because we stay in the remote area. Most of them are basically farmers. Most of the fingerprints are not actually clear enough to be captured. We use sanitizer to clean it. Most of the times after washing with a towel, then after some time we cannot capture. That's basically the challenge I used to face, but we've had a way to get over that by using sanitizers.
Okay. Okay, thank you very much, CCFN Abia, for that wonderful response.
Ask a question, sir.
Okay, you
Can
said?
I ask one question, sir?
Please
Can
go
I
on.
ask one question?
Go on, go on.
Okay, since we are going, yes, sir, since we are going digital this time, don't you think that a bimodal system of identification will help instead of only the fingerprint?
Bimodal, can you explain for those who are not IT tech? Bimodal, how do you mean?
Like, being a unified system, we are looking at identifying them with their fingerprints. But where the PBS is not available, what else can we do to identify such patients since it is not digital? I think the IT can work it out.
Okay, maybe looking at facial recognition and all of those.
Just like that, quite.
Okay, so let me, Mr. Johnson, do you want to respond to this? If there are other possibly or similarly way of doing that in the absence of finger capturing?
All right, thank you, Prosper. Yes, there are other ways of identifying are in the works. But first, we're looking at the fingerprints. When the fingerprints will attain some level of some level of the system being very, very stable, then we can move. There are other ways we can also do. IDs can be generated for those patients, which we can also use to identify them, as we can when these fingerprints are append to an ID, you can also use the ID to verify. As you said, you can also do facials to verify, but it's subject to discussion out of here. But yes, those are thought process that has been spoken to.
All right, thank you very much, Johnson. I move to ABUTH Kaduna CIHP. You're already unmuted. So I want to ask you this simple question. What's your fear about PBS and these PIMS? What do you think, what's your fear? At times, any new innovation that comes, there are always challenges or what you may think. So can you tell me what's your fears about eventual implementation of PIMS, seeing from the PBS that is already active in your facility? Over to you, ABUTH Kaduna.
Okay. Good morning, sir.
Good morning.
Yes, sir. The issue of the PBS is a good innovation and welcome. But the issue now that we are having, my fear now here, the main thing I'm thinking of, because as far as for my facility, we happen to be in a local government that is one of a local government that is having an insecurity challenge. And we have much of our clients that are accessing ARV clinics by home delivery. So the issue of PBS now, I don't know how we are going to extend it to them, because most of them, they are very far away. When you track, then they will give you the feedback that they cannot come to the facility for now. Some is because of the issue of insecurity, while some is because of the distances and they don't know how the road may be. So home delivery is one of the things we are using to make them access their drugs. So on the issue of finger capturing now, so I don't know what we are going to do with those clients. And the next one are the issue of pediatrics. Most times we find it difficult to capture children. So we don't know what are we going to do with those ones so that we can clear our list on that one. I think this is just my own challenge and where I feel how are we going to do. But on the issue of PBS, it will actually going to go far. It's going to create a very good advantage to us because it makes us to have actual number of our clients, and also the issue of missed appointments. Most of clients, they have already collected their ARV somewhere else, but they also register in another facility. When you track, they'll just tell you, I get drug. So they don't, unknowing to them that, unknowing to us that they were accessing drugs in 2 facilities. So with PBS capturing now, that one will be sought out. Every client must be registered in 1 facility. And if the person access drugs somewhere else, we'll be able to notice that this person has drugs. So the issue of misappointment on that regard will be cleared. I think this is my own take on PBS.
Thank you very much. This is very technical. Johnson, why you prefer to respond to this? I don't know, but maybe we also need to start thinking about how we can have maybe an APK that can be sent to this prospective or these patients to actually have their fingerprint done and then submitted. I don't know, because what he said is very key, especially in a volatile area where security is a problem, and then they need to come physically to be able to do this fingerprint. So Johnson, please, do you want to respond to this?
So on that, one is to understand the flow, but I think for this, I think it's a program question, right, Prosper? I think for this, it's a program question, and it's something that we'll take to the program guys to better get a proper flow for this so that we can always incorporate that into the system. So I'll leave that to the program folks. Thank you.
All right. All right. I'm a program person, but let me not talk about that. Thank you very much. So CIHP Kaduna GH. So maybe we will take your question last. You have gone out. Okay, let's have Epin Benue State. CIHP Kaduna GH. Can you unmute yourself? If you unmute yourself, I will see you. CIHP Kaduna GH 12. Okay, so can you tell me what's the benefit of implementing patient identity management in your facility? Are you there? It's like CIHP is not there. Let's move on, please. So Epin Benue State, let me read the Epin Benue St. Anthony's Hospital, Zakibian. Good. So St. Anthony Hospital, Zakibian, can you tell me what's the possible benefit of implementing PIMS eventually in your facility?
Good morning.
Good morning. Can you go on quickly? We don't have all the time.
All right. It reduces the cost of duplications because it reduces the chance of more patients being duplicated on the same database. And it also helps to keep a quality work. But we have some few challenges compelling to this. I have a few questions that I need to ask. Like most of those children, those pediatrics, like children from 0 to 5 years, which they have been enrolled and the thumbprints have not been captured. If they happens to be in a different location or area where they are doing these PIMS, what is the actual identification that they identify them that they're already on EMR?
Johnson, can you quickly respond to this?
Again, Malam Isa is here again. This is what I will leave for the program, guys. Right? What's the flow right now for patients that are below 5? Right? Prints are not being captured for these patients. So when they move, these patients are not the only patients that come. They don't bring themselves to the facility. So what's the flow? As I said, this still speaks to program and what the SOP will be. Just to bring in here, right? For NIMSI, that's our National Identity Management. We do have children below 5 that are not captured, but those are append to their parents, right? When they come, their parents bear or their ward, whatever the case may be. Fingerprints are used for this patient, but in this ecosystem, it's different because you could have the parent and you could have the child being PL HIV. So for this, it still boils down to, okay, I see my director on the call. I think he will be able to help me out on this.
Okay. All right. So, okay, Jibri is on the call, but there are burning questions both on the chat box that you may need to respond. One of them is about how for those in a security challenge area that don't need to move to facility, and they're already using the differentiated service delivery where they pick their drugs or some of their drugs are taken to them in their facility. Now, in a situation where they need to go for finger print capturing, how do they go about it? Is there any other means that maybe an app can be sent to them to do it at their various houses, and then it will be synchronized into the database? And also, these are some of the questions, as well as questions around children that are under 5 that their finger cannot be captured. So Jibril, can you please respond to this?
All right, thank you very much, and good morning, everyone. Can you hear me, Prosper?
Yeah, I can hear you. Please
Great.
go on.
Good morning, everyone. So thanks for the contributions and thanks for all the inputs I've been hearing so far. So this tells me that there's a quite good knowledge around the identity system and also the biometric system. But given those two questions, and I think Johnson tried as much as possible to answer, but just to throw in more light as well, writing on to what he said. So first of all, for security-prone areas, you're expected to also cater for clients, and I mean, that are also categorized as hard-to-reach areas as well. So what I see partners doing so far is basically try as much as possible to reach out to those areas, either by going with a laptop that is movable from the facility to those communities and find a way to capture them. And mostly moving with a laptop also comes with its own risks and challenges. So again, another option is for those also using NMRS, there's also a provision for a mobile version of that NMRS that allows you to also capture fingerprints. So you're also expected to also go with that fingerprint, that mobile app fingerprint, enable to those rural areas and capture their fingerprints, come back to the hospital and synchronize it back into the EMR. So those are the current possibilities that you can achieve by leveraging on the mobile app. So there's already a mobile app for those that don't know. So aside from the main laptop EMR, the desktop EMR rather, you can also use the mobile device to reach out to all those communities that are hard to reach. Then secondly, for children below 5, the program currently is not capturing or is not encouraging partners and facilities to capture children that are below 5. But what is advisable to also partners and facilities is to make sure that anybody from 5 and above, anybody between the age of 5 and 15 should be captured with their biometric. Whatever information you can capture at that moment, please go ahead and capture the patient. Then there's also another guidance that says that once they reach 15 years, you are expected to also recapture that patient back again, meaning that the fingerprints that the child provided at that age might not be enough to be used for any reporting purposes. So once the child reaches 15 years, they are expected to recapture that patient again, that child again, and then have his or her fingerprint uploaded centrally. So this is currently the guidance, and this is what the program is working with at the moment. And I hope that also shed more light. Thank you, Prosper.
All right, thank you very much, Jupri, for that detailed perspective. So I'm going to take last question I'm going to ask last question to CIHP 1-2. So CIHP 1-2, what do you think needs to be done to better things around patient identity management?
All right, good morning. Good morning, everyone.
Good morning.
This is Jafet Silas from General Hospital 1-2, CIHP Kaduna. Well, I think one of the important things that we need to do to better this patient identification management system is, of course, to have to optimize our efforts in ensuring that we have 100% PBS coverage across facilities. When I say 100% PBS coverage, I mean we have quality biometrics capturing. Then from there we'll now build up. I think by the time this PIMS is fully implemented, seriously, it's going to help us in dealing with issues that have to do with duplication of patients, and of course it will be easy for patients to roam, just like the presenter said. So I think one of the key things that we need to do is to ensure that we have 100% PBS coverage.
All right, so a follow-up question on that is that have you had a problem in your facility that you are not able to capture any patients, maybe biometrics, and then if that has happened, how were you able to address it?
Yes, we had cases like that, especially for children, within the age of 1, 2, 3, 4. Sometimes we find it difficult to capture them, of course, because of the nature of their fingerprints. Anytime we have issues where we could not capture any patient, we usually ensure that we fill an incident form to report that we could not capture this patient because of so reason. But so far, I think my facility has actually done well in PBS coverage.
Have you had a case where some patients, their fingers are not complete? Or I know it's very common in our side in the northern part of the country. Maybe 2 fingers are not there, or maybe someone has a leprosy or something. How were you able to manage such cases?
We had cases like that. I think the last one we had was someone that came with only the left hand, and so we were able to capture 5 fingers of the left hand, and of course to augment that, we used the fruit to augment that. So whenever we have cases like that, we use the fruit to augment that.
Oh, really? Yeah. Please, Jonathan, is foot capturing also allowed? Hello, Johnson, or Debris, is foot capturing allowed?
Thank you, Prosper. No, that isn't supposed to be so. It's supposed to be the fingerprints.
Okay. Thank you very much. We have really taken 10 minutes into our time we are really very sorry about that. So at this point, I want to call on the Federal Ministry of Health to give us a closing remark. CDC, they have taken permission, they've jumped into another call. So can we have FMOH give a closing remark?
Well, thank you, Prosper. Please, I would like to delegate Israel Obaja. I can see him on the call. He can close the meeting. Israel Obaja, kindly close the meeting, please. Israel, are you there?
Yes, Labake, good morning. I'm here.
Yeah, you can please close the meeting.
Okay, good morning, everyone. This was a very great session, very interesting and enlightening. I hope we put all this to use and also to enhance service delivery in our facilities. Thank you all and have a great day.
All right, thank you very much. And from all of us here at Phase 3, we want to say thank you. We will share the slides and then the links to the recorded session so that you can also have access to it. We look forward to having you again next week. I will be packaging another interesting one for you. Thank you to Johnson. Thank you to all the facilities that provided response and in-depth into the PIMS series that we had today. We want to encourage you to join again next week and we will provide further. Thank you very much and bye for now.
Thank you.